Hello, as we come to the end of our 440 course, we have just a few more points to remind you of to have you ready for your testing. While we're in our testing environment, along with all the personnel and supplies that you need, remember that you also have any orders that are needed. Unless it states otherwise, when care is needed, it is presumed that orders that are needed, especially any medication orders that the patient may need, they are already on the books. You don't have to stop and think, well, do we have an order for it? If it's in the question asking for it, you can assume that the order is there. Your patient should have advanced directives set up in their chart. Now remember, this isn't just DNR or simple as that. They can choose whatever level of care they wish if something goes wrong. They might choose to go to a hospital or not go. They can have heroic measures or just simply do an IV, and if that won't do it, they would choose not to accept any further treatment. A proxy should be chosen with the paperwork. That is the person that will be making the choices for the patient if they are not able to choose for themselves. So what would your role be in that case? You want to be familiar with what their healthcare choices are if they are not able to respond, but it is not up to you to change it. If the patient desires change within their advanced directives, it would be the PN's job to notify the physician. It is not within the PN's scope to make changes to the directives. This graph is a flashback all the way back to your prerequisite course. I'm not going to cover each one of these lines, but the idea is review it and keep in mind what kind of symptoms would go together. Would you have an opening of bronchial airways? Would that be matched up with dilated pupils? Or would you have constriction? When would we expect to see sweat stimulated? The symptoms tend to come all together depending on what kind of sympathetic or parasympathetic effect that you have. While providing care to our geriatric patients, we know to expect confusion at times. An important aspect of that is pairing up confusion with fall risk. There is a significant safety concern there, and we always need to make sure we're addressing that. If somebody is confused with risk of falling, that's going to become a priority. We need to prevent injury. And of course, with a geriatric patient, confusion can often be paired with potential UTI. While communicating, remember to speak in a slow, loud voice. If able to, get down to more eye level. Don't want to be towering over somebody who's in a wheelchair or something. If they are using devices such as hearing aids, it would be a good idea. We want to review how to take care of a hearing aid in particular. Removal, cleaning, replacing battery, putting it back in. Make sure you are familiar with the steps and what needs to be done there. Watch for indications of impending death, such as mottled skin or Shane Stokes type breathing. Remember, that is alternating periods of deep and shallow breathing, and then apnea. And what tends to happen is that period of apnea tends to get longer and longer until they no longer resume breathing. When we have somebody who's what they call actively dying, we're going to be providing comfort measures, especially if they present a person in palliative care. We're not going to try to do any heroic measures. We're not going to be trying to fix any problems. What we want to do is make them as comfortable as possible. This may be with medications ordered. It might be as simple as providing them a nice soft blanket to keep them warm and they're in time. Let's make sure we're watching for what level of care this individual needs. While working with a patient with psych diagnosis, just like anyone else, safety is going to be the highest priority. When meeting somebody for the first time with the psych diagnosis, you'll want to introduce yourself, let them know who you are and your position so they know you're somebody who should be there. You want to be honest with them and demonstrate acceptance. Arguing is definitely not going to help. If they're having a rough time, you don't want to leave them alone. Remember, when you have a psych diagnosis, that presents a higher risk. If they are left alone, that is potential for self-harm. If there is any apparent risk for self-harm, maybe they're making a statement like, I can't take it anymore, be direct. This is not the time where you want to be gentle. Ask. Have you had thoughts of causing harm to yourself or maybe even ending your life? This will apply with the testing setting and real world. In a real world situation, especially when it's something new to you, that might be very uncomfortable, but it's very important to just be direct and make sure this person is taken care of as much as you can. You may have patients who have hallucinations. Perhaps they're standing in the corner talking to themselves. You may not be sure, so again, direct approach. Ask them, hey, are you hearing somebody's voice? Are you hearing something? Maybe they were just thinking out loud. Some of us do that. If they are hearing voices speak, next thing we want to find out is, what are they saying? It could be as harmless as, oh, let's eat our cupcake last, but what if it's go stab your neighbor or cause self-harm? It's going to be important that we know what's going on as much as we can in their mind, so if they need additional help, we can provide it right away. You may have a patient presenting with anxiety. In that case, one important thing we want to do for them is to decrease the stimulus. Try to find a quiet area. Keep your questions simple. You want to make sure you're establishing trust, providing a safe environment, and again, if they are having anxiety, we don't want to leave them alone. That just opens the door for something to go wrong. You may also have a patient with OCD. They might have certain behaviors that they need to get through. As long as it's not a behavior that is dangerous, because we'll always put safety first, limit the time that they're doing things, but they might need to be able to complete whatever task that they're doing before mentally they can move on. A good way to help them out is try to encourage a progressive decrease in the activity. Odds are it might not end, but if we can have less symptoms, that will be beneficial for the patient. A good HESI hint that's found in your review book: the best time for learning for your OCD patient is after completion of a ritual. That's when the anxiety will be at the lowest. And if they are having any kind of delusions, be sure not to argue with them. We don't want to have any kind of confrontation, but be honest. Our last slide is going to be focused on leadership. You may be asked what task you would assign to a UAP. Or they could put it the other way around where all the tasks but one could be assigned to a UAP. So be careful, watch the wording, make sure you are choosing the task appropriately. You'll definitely want to review what can and cannot be delegated to unlicensed personnel. And if it comes up in question form, how do you look this information up? Your main resources will be the Nurses Practice Act or the facility policy. Since you will be the licensed nurse in a testing scenario, you'll be tasked with instructing the UAP or determining if they need further instruction. One of the best ways to determine if further instruction is needed is just by observing what they do, and that will enable you to determine what the needs are. Keep in mind they may present a video or a written situation and expect you to be able to identify what's being done wrong, or they might just be doing it correctly. You might not need any further instruction. When they have a patient with bleeding precautions, usually they won't put it so plainly. That'll be stated something like the patient has a diagnosis of thrombocytopenia. So in that case, we're going to do gentle handling, preventing any kind of injury. Safety is going to be the main consideration there. Care may be provided for a patient with an IV by the UAP. Very important they know, never disconnect the IV. They don't shut things off or disconnect it. If they need to do something like change a gown and they have an IV line, no snaps, they could possibly have to even take the gown off and route it through the tubing and over the pole. But we have to maintain the IV, make sure it never gets disconnected or stopped. If presented with some form of insubordination, safety and patient care is still going to remain the #1 task. So whatever situation that's presented, remember what the goal is, what needs to be done. Look at your options, you search for the one that will actually complete the task. Any kind of disciplinary action can come later, but right now, the patients need to be taken care of. Similar idea if you have conflict between a patient and a UAP. We got to take care of the patient first. Conflict resolution is a secondary thing. First, though, we need to end the conflict. So if they do have arguing or something else going on, we have to find the option that ends the conflict then. Typically, they won't tell you any kind of background to it, so we don't know how anything got started, how severe anything was. You just got to keep in mind what is best for the patient care and for safety. Don't jump to immediately sending anybody home, because remember, though the UAP might have been doing something that they shouldn't have been doing, if you send them home right away, now everybody that was in their care, they have decreased care. So being short-handed makes it a lot harder. The other co-workers will have to take over the patients, and now all the people on your floor will have less care. All right, so that was a few thoughts to end our presentation here. I hope this can help you out. Good luck with your studies, and good night.